I do want to start by acknowledging that I'm doing this presentation today on Treaty 1 territory, and I'll do a bit of an introduction about the territory that I'm from, but that's where I find myself living and working, and I have been in Treaty 1 territory since the age of 2, and so I call this home, and I'm very grateful to the Métis, Anishinaabe, Oji, Cree people that I live around and work with and am friends with, who have welcomed me into their family. So with that, I want to just talk about what I'm going to spend about 25-30 minutes going through with my slides, and when John is able to join, then we'll talk about some of the other objectives that he's going to speak to. So what I thought I would talk to you about today is what is research, and I know everybody in this room is very familiar with what research is, but I want to talk to you about it from my perspective as an Indigenous researcher and how I look at research. And then I want to get into the impacts of colonialism on research. Again, this is something that could be an entire graduate course, but we're going to go through it fairly quickly, but hopefully hit the high points of that. And then once we look at what how colonialism has impacted research, then I want to talk about and explore some ideas around how do we decolonize research, and what are some practical ways that we as researchers, no matter what our identities are and where we find ourselves in our training and in our work, how can we move this forward within our own spheres of influence? Because I like to always, anytime I'm doing a workshop or a talk like this, is to leave you with some ideas of how you can start working on that from this moment moving forward, because I think that's what we're all here and why we sign up for these types of talks and workshops. So so it's an ambitious outline, but I think we're up to the task, and with that I'll get started. And I think, you know, when I think about research, as an Indigenous person, I can't help but start with my own location. That is, to me, front and center of how I look at research, which might be a little bit different than how you, and actually, frankly, how I was taught to think about research in a very objective way that kind of tries to remove myself from that research process. And I've actually done a lot of work to put myself back in and to locate myself at the beginning of the research process. So I just want to start by sharing a little bit about my story, just so you have an idea of who I am and how I approach research and how I see research. So I want to start by saying that first and foremost, I'm a daughter, I'm an auntie, I'm a sister, and as you can see from this very little picture, there's a lot of women in my family. We're a very matriarchal family. I trace my identity, my Indigenous identity, through my mom, who is a residential school survivor from Saskatchewan, from the Qu'Appelle Valley area, and I'm very much connected to the women that came before me, the generations of strong women who survived through the various assaults of colonization that directly affected my family. And I'm really pleased to see the young women who are just being born into my family. There's a number of toddlers, all girls. We have a lot of girls, and one who's on the way any day now, due to be delivered by one of my nieces, just waiting to hear the call that her baby has arrived. So so very much connected to my family, and that's a big part of who I am. Another big part of who I am is I'm a member of the Indigenous community. My band is in Saskatchewan in Treaty 4 territory. It's called Peepeekisis Cree Nation, and it's about an hour outside of Regina. I have some family, some extended family that lives there. A lot of my mom's generation actually relocated to Winnipeg following their time in residential school, but I still maintain connections to that community, and it's very much part of who I am. And as I mentioned, I've lived in Treaty 1 territory since the age of 2, so I feel very connected to the Indigenous community locally, and it's, yeah, part of who I am as well. Part of what I do outside of my formal academic work is I've always been involved in the creative arts. I was a clothing designer before I switched fields around my mid-30s and ended up going into medicine and went into health research. But I'm actually in the process of reclaiming some of my traditional connections to art through beadwork, and I've been exploring that and producing pieces, and actually was part of an online exhibit last year of that around doing a piece related to COVID, and I did it in beadwork, and so it's something that is also part of me and helps me to heal and to cope with a lot of the stresses in life. And finally, a big part of my life right now is I'm a PhD student. I'm in the final months, I think, of my life as a student, and hoping to graduate soon. And I am also on faculty. I was fortunate to be successful in competing for a faculty position at the University of Manitoba in the College of Medicine. So I've got a very full life when it comes to my work. So busy trying to write up my thesis and get that done. And so all of that, all of those aspects of my story and more come together and are part of who I am as a researcher, and are part of how I look at the world, and of course are how I come to look at the research that I do. And so I really try to, I share this to be transparent in how I've come to be a researcher, and how that actually is, I can't separate that from the research that I do. And I just, I've gone too far. And I just, share this as a way of telling you that there's many aspects to my story, some that I've shared, some that I haven't, and it all, they're all pieces of the puzzle that make up who I am. And you would have similar aspects to your story, I'm sure, and many different pieces that form who you are. And so we all have these stories. And, when we think about sharing our stories, we always make decisions about what pieces we share. And some of what we share is a function of what we're being asked to share. So I might ask you questions. If I was doing an interview with you as part of a research study, I'm deciding what questions I'm asking you. But you're also responding to who's doing the asking. And you're making decisions about who's asking, why are they asking it, and what parts of you're going to share. And so when we think about doing research, we need to keep that in mind, we're getting parts of stories, and it's all of these things are coming to play in that moment, and that's part of the information that we're gathering, and it's within this realm of who's doing the asking and what decisions that are being made on the fly about what I'm going to share. And all of what we're doing in that process of sharing stories is determining what we can learn from each other's stories, what you're sharing with me and what I'm hearing, and how I'm understanding that through my position, through the person that I am, from the, all my experiences to date, all influence how I understand your story. And hopefully, if we're doing this in a good way, which is kind of at the basis and the fundamental part of doing research from an Indigenous worldview, always thinking about how this shared knowledge, how two different perspectives are coming together, and we're sharing this knowledge, and we're sharing an understanding, and how are we using that knowledge in a good way to improve health. Like that is, what I think of every time I do research. And so that's really at the core. So when I think of research, this is kind of one way that that I've come to think of it, and that I try to keep in mind when I'm going through the research process at all stages. And so when I'm thinking about this from working within the realm of Indigenous health research, which is the area that I work in, I'm involved in research that always that somehow is connected to improving the health of Indigenous people. That's my specialty, that's my interest, that's my passion. And so I'm always keeping in mind that there's all these different aspects to the research story, the data that's being gathered. And part of the story may come from biomedical data, may come from blood tests that we're doing, could come from other diagnostic tests that are being done. And that's one aspect of the story. And you can get a lot from that, but I would suggest that you're not getting the complete story. You're not filling in the whole puzzle if you're only getting that and not putting it in a bigger context. So how do we put that in a bigger context? Well, we might talk to patients and find out about their experience of being a patient, of having an illness. We can ask for different aspects of that experience, maybe through qualitative interviews. So there's a lot of different ways. So we can get a fuller picture. So we have, the biomedical data, but then we're also getting, filling that out with the patient experience. So the picture is getting a little bit clearer, a little bit more detailed. And then we might consider health behaviors, which is a big thing that we look at in health research. What are people doing that's promoting health, that might be detracting from health? So getting a picture of how they're managing their health and the things that they're doing to promote health or not promote their health. And again, just adds to another aspect of filling in that picture and getting a more complete view of the situation. And we may even go a little bit further and look at the family context or the community context, and once again, see these bigger, more distal influences that are playing a role in maybe influencing the other aspects of the data we gathered. And this is a lot of what we do when we think of the social determinants of health, is that we're looking at these other factors that are outside of the individual. And so again, once again, we're getting a pretty complete picture, and we could stop there. And a lot of research, does exactly that, looks at all these different aspects, and you could argue that you're getting a pretty good picture, a pretty 360 view of the situation that you're studying. But what I would suggest when you're doing research that is looking at issues related to Indigenous health, that you can't stop here and think that you're getting a picture that's good enough. And what I would say that you need to consider is to look at all of these factors against the backdrop of colonialism and the impacts of colonialism on Indigenous individuals, families, and communities, historically and in contemporary times. And you need to put that frame around the story that you're gathering if you truly want to understand why something is impacting the health of individuals who are Indigenous or families or communities. So that's why I want to really spend a lot of today focusing on colonialism, and also looking at how we can disrupt colonialism in our research and how we approach it. So with that, I want to just very briefly, this is going to be a very, very quick tour through colonialism, but hopefully nothing that you haven't heard of in the past. So hopefully a review. So as you probably know, all forms of colonialism are a practice of domination. It's when one people comes to dominate another group. And it's an imperial nation that seeks conquest of an area to rule over it. And it can take a couple different forms, but what I want to focus on, because we are situated in Canada, and the form of colonialism that happened here and is ongoing is known as settler colonialism. And so that's when the Indigenous population, the goal is to replace the Indigenous population with the invasive settler society. So in our case, it was England and France that led the way, and the process of doing this to take over the land, to impose British and French culture as the way of that we operate, and that the worldviews that dominate on these lands after colonization started, and eventually through this process of settler colonialism, that those settler societies develop sovereignty and a distinctive identity over time. And this is what we're left with in Canada. A lot of times you'll hear people refer to it as in the past tense, but I think anybody who, any Indigenous person, anybody who works in this field recognizes and can make a very strong argument that that colonization is ongoing, because it has formed the structure of our society, and it continues to oppress Indigenous people. So it's a mechanism that is continues to play an active role in the lives of Indigenous people through a number of different ways, through all of the structures, the social structures that have formed in our society, through laws, through policies. So it's continuing to act on us in a very real way every day. And colonization is, and particularly settler colonialism, is predicated on control over lands. That's the driving force of colonialism, controlling lands, and of course controlling resources that are in those lands, and predicated on the ongoing elimination of the Indigenous population. Okay, so why do I say that? Talking about eliminating the Indigenous population, and maybe, you might think, okay, well, maybe historically, but that didn't happen. Like, clearly I'm sitting here, I'm talking to you, I'm an Indigenous person. There's many Indigenous people here. We were not technically eliminated, but I would get you to think about elimination perhaps in a different way. And I want to just highlight a few ways that elimination tends to manifest in society. So the most obvious way is death through homicide, or indirectly through neglect, through starvation, restricting resources so that people can't continue to live and actually die. And that is something that we saw historically in the early days of establishing Canada. But elimination can take other forms as well, through assimilation. So Indigenous people are here, but have they been assimilated to living and thinking and doing things from a Western way of life? So that's another way. So when we become assimilated into the dominant culture, that's a way of eliminating our identity as Indigenous people. Another way is through segregation. So separating Indigenous people from fully participating in society. And that was a very clear way that was done was through the reserve system. So removing Indigenous people, First Nations people specifically, and moving them onto reserves, and actually limiting their ability to participate in the dominant social institutions. So not even being able to leave the reserve without permission, not being allowed to engage in trade, certainly not being allowed to be in any of the institutions like the mainstream school system, mainstream healthcare system. There was Indian hospitals specifically for Indigenous people. There were, of course, residential schools specifically for First Nations students. So kept separated from the main population. And while we all know from, from all of the attention paid on, to residential schools and that history, we know that those don't operate today. But there's other ways that segregation looks today, and that can be through densities of populations in the inner city and in the poorer parts of urban centers, that where a lot of Indigenous people tend to might be in higher concentrations, and for a number of different reasons that are related to colonization that restrict opportunity and place you at an economic disadvantage. And other ways of forms of social exclusion through racism, where you would not be able to fully participate in the social institutions of the dominant culture. So just some examples of how elimination may look that you might not think of and are not as obvious. So I want to just briefly, I found this YouTube video that I want to share with you because I think it really speaks to the ongoing impacts of colonization, and does it through a historical recounting of some of the events of colonization. And I found this really powerful, and I think it's worth taking a few minutes to watch. It runs for about 5 minutes, so I'll just start that now.
The buffalo always sustained us. The newcomers saw this. When they started killing them off, we started to die from hunger. Our leaders realized we had to find a new way to live. They came together at Fort Carlton and Fort Pitt in 1876 to meet the Crown's representatives. They negotiated our future through Treaty 6, a nation-to-nation agreement. Our people were told that the newly arrived Northwest Mounted Police were there to protect us. Livelihood, education, health care, hunting rights, and more were all promised in exchange for sharing the land to the depth of a plow. We were told we kept our freedom, and because the treaties were done through our traditional ceremonies, most believed the promises made by the Crown. No one knew the Government of Canada was preparing the Indian Act at the same time, which said Canada could dictate our lives. No one knew the Northwest Mounted Police was there to push us onto reserves. No one knew the written document said we surrendered the land. Big Bear and a few other leaders wanted to negotiate a better deal. Government representatives, like Indian Affairs Commissioner Edgar Dewdney and his assistant Hayter Reed, wanted them all to move away from the coming railway, so they used hunger as a weapon against anyone trying to resist. Big Bear tried to choose a reserve near Little Pine and Palmaker, but it was not approved. He and his people were sent to Frog Lake, Alberta. The government brought in an Indian agent named Thomas Quinn, who had a reputation for cruelty. He continually refused rations to the starving people. Another man, John Delaney, forced the women to trade their bodies for food for their hungry children. On April 2, 1885, the Cree warriors, led by Wandering Spirit, finally pushed back with force, killing 9 men they knew as their oppressors, including Thomas Quinn. The reserves in the Battleford area were also kept hungry. A group of leaders and warriors went to Fort Battleford to meet with their Indian agent to ask for food. The people of the town of Battleford got scared and barricaded themselves into the fort. When the Cree and Nakota arrived, the Indian agent refused to come out, and so some of the hungry people took what they needed in the deserted town. The government was already sending troops north from Swift Current to find and punish Big Bear and his warrior chief Wandering Spirit. One troop's leader, Colonel William Otter, decided on his own to attack Poundmaker's camp. Palmaker went to Little Pine and Sweetgrass, requesting the warriors come to his camp. He felt that a large number of worthy men would convince Otter to turn back. Otter attacked before dawn. He fired into the Cree camp without negotiating. But the warriors protected the people and defeated Otter's troops. Eventually, Big Bear, Palmaker, and Wandering Spirit turned themselves in to ensure safety for their people. Big Bear and Palmaker were sent to Stony Mountain Prison. On November 2nd, 1885, 8 warriors, including Wandering Spirit, were tried without legal representation and sentenced to death. The government brought people in from nearby reserves to witness the hanging. Children from the residential school in Battleford were also forced to watch, to be taught what happens if they stood up for themselves. People are starting to learn about these schools and their terrible legacy, but they don't know about the other ways the Canadian government has oppressed us. The rights outlined in our treaties were ignored and overshadowed through the Canadian government's policies and laws. The Indian Act took away our traditional governance structure and imposed a chief and council system. The Indian Act criminalized our ceremonies, which is a way of criminalizing who we are. Because of what happened in 1885, the government introduced a policy called the pass system. This meant that our ancestors were confined to their reserves unless they had permission from the Indian agent. When our people began to pursue land claims and organize against our own oppression, the government added a section to the Indian Act that stopped us from hiring lawyers. Soon, we were outlawed from gathering in groups of any kind. The RCMP enforced it all, arresting anyone who resisted.
So yeah, so much in that video, and I'll be sharing my slides with Linda after, so that you'll have these, and if it's helpful to you, and if you want to watch that again. But just what I'll say and what I see, or at least what I see when I watch this again this afternoon, is the long history of my people resisting, and also seeing just how colonization works at every turn to try to oppress us whenever we are standing up for who we are and just wanting to maintain our identity and maintain our way of life, or to reclaim that there's always another new mechanism that's put in place to shut that down. And sometimes those are really obvious through changes in laws, and sometimes they're less obvious. But so that's what makes fighting back and reclaiming our way of life so difficult, because of that ongoing structural oppression. Having said that, we are very much as a people pushing for decolonization, and this is something that is an ongoing project, and will certainly outlive my life. And really, it's about reclaiming what has been taken from us as Indigenous people: land, culture, language, relationships, health, everything that's been robbed of us through colonization. And part of that is redefining the relationship between Indigenous people and settler Canada in systemic ways and in interpersonal ways. And I think a lot of the work of reconciliation is really around that. At least that's the way I see it. And so this, I really, I wanted to spend some time talking about colonization in the bigger sense, to really bring this down to how does this impact us as researchers. And so health research in Canada, all research, but health research in particular, has a really troubled history in Canada when it comes to Indigenous peoples. A few years back, in around 2013, Ian Mosby published a study that gained a lot of attention about nutritional studies that were conducted on children in residential schools during the late 1940s into the 50s. And many of these nutritional studies actually involved restricting calories and starving children and studying the effects of that. And of course, were done without any knowledge of the parents and no consent. Another one that hits closer to home for me were vaccine trials that happened in the residential schools in the Capel Valley region, which is where my family went to residential school. And in particular, my mom in the early 1950s studied nursing in St. Boniface Hospital in Winnipeg. And actually, when she found out about these Capel vaccine trials because the results of that study were being presented to her while she was a student, and she was horrified to find out that it was just being presented as a matter of fact thing of this was done, and this is what we found about testing these vaccines on First Nations children, and this is her community. So some really horrifying things. And these are just two that I've chosen to highlight today. In more contemporary times, it could be researchers coming in, collecting data and not sharing it back with communities, just kind of this helicoptering coming in, taking what they want, building their careers off of that, and never doing anything, bringing that back or working in partnership with communities to ever use that research to improve health outcomes for the communities. So a lot of times, certainly a lot of communities have said, we've been researched to death. This is there's just this very difficult history, and they don't want to participate in research, because of this, and don't want their knowledge and their stories to be appropriated or to have their knowledge taken and without their participation. So as a result of this problematic history, there's been a number of reports and that have been written and published. The first one being the Royal Commission on Aboriginal Peoples that was published in 1996 and identified these issues of problematic research ethics that had happened and that this needed to be addressed. That led to, a couple of years later, the OCAP principles, ownership, control, access, and possession of research data being under the control of Indigenous peoples and communities as a way of ensuring self-determination and research data governance by Indigenous communities. In 2007, CIHR went a step further and developed guidelines for health research involving Indigenous peoples. And 7 years later, that was further developed by the Tri-Council agencies, so NSERC and SHRC as well, having a joint policy statement around Indigenous research. So a number of steps have been taken now to ensure that unethical research doesn't move forward in Canada, and and what if nothing else, I want you to remember, this kind of statement: nothing about us without us, which is something that we hear from Indigenous communities, and I would say, this is how I look at research. I not going in and doing research in community without the full involvement and full partnership with community people. And John is going to speak to that a bit as well. And just to also, invite you to whatever community you find yourself working with, to explore whether there's local protocols and documents that have been produced to help guide engaging in research with local Indigenous communities. I'm situated at the University of Manitoba. We actually have a document in the Faculty of Health Sciences that specifically speaks to our local context, and this is something that that you can look into wherever you are doing your work. So I'm going to just quickly kind of go through this and just mention that epistemology is something that I think about a great deal. Basically, it's the way that we view knowledge, and it is functioning for us as researchers, whether we're conscious of it or not. It defines helps us define whether knowledge is seen as valid and true and legitimate, and what are the appropriate ways of gathering knowledge. As a Western trained researcher up until, very recently, I tended to think of that in very, positivistic terms, so very detached, objective, very much a Western worldview, and now I find myself as a person who, as an Indigenous person, is embracing Indigenous ways of knowing, making space and centering other ways of knowing, including dreams and ceremony and insights that come from being on the land, as being valid data alongside data that's collected through Western scientific ways. And so epistemic racism is something that occurs when we position the knowledge of one group, such as Eurocentric way of doing research, as superior to another. And this is something that I actually internally challenge myself all the time, because learning things from a Western biomedical way is so firmly rooted in me as a student and as a researcher, that I'm constantly finding myself pushing back on that and making space for an Indigenous way of knowing to be at the center of the work that I do. And so I'm getting near the end here, but I just want to very quickly highlight kind of some ways from an Indigenous worldview that are ways that I think of when I'm approaching research. Knowledge from an Indigenous worldview is always connected to relationships. So with people, with place, with the physical, the emotional, the mental and spiritual aspects of life. So that real holistic view. And there's this interconnectedness between the physical and the spiritual world. And so when I just mentioned to you that I'm incorporating dreams and visions and intuition into the way that I'm gathering data for my thesis, that is from this worldview of like not seeing any distinction or barrier between the physical and the spiritual world, and that the spiritual world has a place in informing what we understand in our day-to-day life. And at the soul of all of this is doing research in a good way, so that always speaking the truth, honoring the relationship to the communities that we are working with, and trying to act in a good way and to share the knowledge in a good way. So you might ask, and I get asked this all the time, that's great, Linda, I'm not Indigenous. What can I do to decolonize research? And I'm going to, in the interest of time, skip through. I'm not going to show the video that I have, but I just want to highlight what you can do. And so decolonizing research really focuses on decentering the aims of the non-Indigenous researchers. So when you're partnering with Indigenous communities, taking yourself out of the equation and putting the Indigenous people at the center, and always making sure that you're responding to the agenda of Indigenous people first and foremost, and that you're providing ways for Indigenous people to make sense of their own reality. So they're involved in interpretation of the data, and it's not just a Western or non-Indigenous person who's interpreting the data, and that the research is responding to community agendas and what the community wants to see as informing the research. Of course, this would also include fully honoring the voices and perspectives of Indigenous people, and also incorporating the principles and guidelines of engaging in research that have been developed by Indigenous communities. And I'm going to just leave it there, and I'm hoping that John has been able to join. I haven't been keeping track, so do we know if John's on? Ah, there you are, John. Awesome. Okay, well, I'm going to stop talking and leave it there and pass it over to you.
Why don't we take maybe a couple of questions for you first?
Yeah. Okay.
That was a fantastic talk. Sorry, I had issues on both my computers. Luckily, I had a third one here.
Oh, thank God for the third one. Okay, yeah, for sure. Happy to take questions. Yeah.
We need some brave souls.
I see Oliver has his hand up.
Okay,
go ahead,
great.
Oliver.
Hi there. Sorry, just my little daughter just fell asleep, so I need to move. Thank you for the presentation. I thought it was great. I think so just a little bit of a background, and I want to seek your wisdom, and also maybe a bit of thought-provoking question. So I'm very interested so I have a master's in public health, and I'm really interested in public health and health services research, and how we can better design care for people in it. And obviously, so Indigenous populations navigate the healthcare system differently. But oftentimes, I'm from Quebec, some of the time in my center, they're not a dominant, they're not a big group. The Indigenous populations tend to go to the other pediatric center we have in Montreal. And so, I'm trying to be cautious here. And I think that's part of often the tendency for especially young researchers is that the cost of entry of doing research that touches on Indigenous populations seems so high that it frightens many of us, and that includes me. And so we'd rather look at other populations where things are not as difficult to learn, I want to say. It sounds wrong, but you're nodding, so I'm probably not the first one mentioning that to you. But Indigenous research on Indigenous issues will never be my main focus, but it could be part of my research. But it seems like it's really hard to do part-time. And how do I go about this, especially when there's not one single people that would be in contact with? Does that make sense?
Oh, that makes total sense. And I don't know that I have like a really great answer. Yes, absolutely. I've heard this from so many graduate students for many years. In fact, sometimes even have supervisors who just are saying like, oh, you'll never get your master's or PhD done, and try to steer people away. And then the other aspect of this is when you're, and this is common in urban settings, where you have multiple identities, and there's not one clear community. So it makes it very difficult to, say, partner with a specific community. I'm just thinking of Winnipeg in particular, where we have like a high Indigenous urban population, but nevertheless, it's not like everyone is from one particular community. So it makes it that really challenging to, how do you engage with, and find that community to do the partnering that I'm telling you that, advise you to do. So one way that you might consider, because it sounds like, and I'm not, familiar with your research, but if, it's kind of a mixed sort of population situation, one thing that you might do is, once you kind of have a feel for, a little bit about the Indigenous population that's accessing the particular facility or whatever program that where your research is situated, is to look at whether there's community organizations that are also involved as a way of engaging with with at least an organization that perhaps doesn't fully represent that population, but has a lot of involvement with the urban Indigenous group in question, as a way of starting a conversation and starting that relationship, and perhaps finding a way to have patient advisors as being a small group that can help to advise you on your research, as that intersects with that population. John, do you have any other ideas? I mean, you do this type of research all the time as well, I think. So, happy to pull you into this very difficult question.
That's okay. Yeah, I think CCHCSP is doing a great job in this regard, that not everyone has this expertise, but you need to create space for people who do it. And you need to understand that it's important in your clinical work that even though the numbers are low, there's a need there, because across so many, mostly chronic conditions, the disparities are wide and broad, and they can be addressed by working with community. So when living and working in Canada, these are the lands of Indigenous people. So I think we also have a moral responsibility to engage in that. And so if you're not ready for that journey yet, or you don't see the connection yet, create space for people in that group who are doing that kind of work.
Thank you.
So for the sake of time, maybe we switch it over. So awesome talk, Linda. And I think, so just building on what Olivier was saying there, number one, having an Indigenous scholar like Linda present to us is absolutely essential when trying to learn this, right? And so creating space for Indigenous scholarship in your institutions, in your training, working with trainees. You'll all be mentoring trainees and teaching trainees. And so bringing that into the fore is critical. I'm coming to you as a settler scientist. Whoops. And I am very fortunate to have worked with Linda and learned from Linda, teaching a course at the University of Manitoba on cultural safety. But I've had many teachers and mentors throughout: Dr. Barry Lavalle, Leona Starr, Elders Barb and Clarence Nepanek, Malcolm King, Dr. Alex McComber, Elder Jack Robinson, and a trainee, Taylor Morso, or some. My wife is on the call here. She's also helped me in that regard. And my own story as a settler, I came to this space of pediatric obesity, pediatric type 2 diabetes from a biomedical standpoint. That was where all my training was. But I was invited up to northern communities to work with Indigenous youth to try to build prevention programs as a PhD scientist. We worked with the community and responded to their needs. We created spaces in the school that the community wanted. We tried to address areas of food security and training of people in the community. And we also listened to youth through photo voice projects and things like that. So I had to go way, way outside my comfort zone to try to get a sense of where the needs were. And based on those experiences, they've really shaped how I see myself today. As an Irish and German settler in Canada, third generation as a father and a partner, and someone who loves prevention of chronic diseases. But first, I think if we could just take a minute, if you have a pen beside you and a piece of paper, I know we don't use those anymore, but write down why you think these disparities exist. So Jennifer Walker, an Indigenous scholar at Laurentian, demonstrated that among First Nations adults, prevalence rates as of 2014, 2015 were 17.6% for First Nations. For non-First Nations white, they were 6%. For pediatrics, Ray Ann Schulman at Sick Kids and Beju Shaw at ICES published this. So going from 95, where rates were quite similar, out to 2014, where Indigenous First Nations youth were twice as likely to live with type 2 diabetes. Maybe write down 3 or 4 reasons why you think that is. And I want a brave soul to step up and answer that in a couple of minutes. So our goal today, or my goal today as a settler for this talk, is to say, what's our responsibility as a non-Indigenous person in this space, working in research? How should we define ourselves and where should we go? So I think when I was training, this was the pervasive viewpoint. I'm not the problem. I had people tell me diabetes does not know race. You have beta cells, you have muscle, you're either insulin resistant or you have a beta cell defect, and that's why you get diabetes. There's nothing different between people of color or Indigenous people and white people. So that's where the world I was trained in, I think that still exists. Many of us today live in this world of guilt and shame. White is not right, but I'm not really sure what to do. I appreciate what's happened, but I'm not really comfortable knowing where to go next. And I think where we would like people to go, and I think a commitment on the part of CCHCSP, is to move the trainees and move the next generation of researchers and clinicians into this space where we're taking responsibility, that we can do right, and that we will join alongside our Indigenous partners towards collective action. And a quote I really like from Jesse Wente is that, I'm not really interested in working with allies anymore. I need accomplices. Because really what Indigenous people are asking us to do as settlers is to join them in the fight for equity and the fight for the rights that are there in either the treaties or in the UN Declaration of Rights. As of 2020, 30% of healthcare workers have reported that they directly see racism in their provider-client interactions. And 13% of providers answering a survey actively say that racism doesn't exist. So your responsibility to move up that ladder is even more challenging because you're facing racism every day with colleagues, and you have many colleagues that are so far down this ladder that they don't think racism exists. And they may also believe that we're all the same and that people should just assimilate. This came to the fore, I think, last year. A great example of this was a podcast with the editor for JAMA Internal Medicine, where he explicitly stated that physicians absolutely are not racist. How can there be structural racism in healthcare? And I think we're doing a disservice to the medical field by even talking about it. He quickly lost his job as the editor of the journal, and also the overall editor for JAMA, Howard Bachner, also lost his job. So this work to move the needle, to push trainees, to push ourselves into this space is going to be challenging because the old guard is still maintaining and has a lot of power is still maintaining this concept that racism is not there because they're white, because they don't see racism, because no one calls them out for being white, and no one attributes their whiteness to any health-related disparity or any health behavior. Going through this, there were some beautiful slides from a presentation I'd done with Taylor Morso, who's an Indigenous trainee here in the DREAM theme at the University of Manitoba, a PhD student. So I just want to provide this as a starting point, that this old guard kind of Western training is that race is a biological identity and a risk factor. So in the guidelines, not going back many years, you would see that indigeneity is a risk factor for diabetes, where I would argue that the society that Indigenous people live in and the racism that they experience is the risk factor, not their race. That race accompanies a biological basis. And as Taylor says, it skirts around the issue that colonialism or racism have any impact on their health or well-being, and that it's purely physiological. We often apply in the biomedical world a deficit-based perspective, so that certain groups are affected by these diseases and they need to be studied or they need to be saved, and that there's a potential benefit for them to participate in research, to engage in the work that we do. Again, suggesting that what we know is best and what we're doing will help, and that the disparities that exist may be individualized and not structuralized or brought to the level of society. And then again, suggesting that certain disorders are only the disorders of Indigenous people. So diabetes as an Indigenous issue, for example, is ostracizing individuals, and that science by itself is apolitical. So talking about colonialism and structural disparities is not actual science. Science is biomedical, science is mechanistic and reductionist. So I argue that as researchers, we have moral, legal, and scientific merits for engaging Indigenous people in the research process. And when working in almost any area, trying to consider how the questions that we're asking could impact the health of Indigenous people. So first and foremost, our moral responsibility is that there was a rich diaspora of Indigenous people living on these lands way before we got here. And we have, over hundreds of years, systematically incorporated laws for the sole purpose of cultural genocide, to remove people from these lands, remove their culture, remove their language, destroy their ancestry, destroy and murder their children, so that we can take over these lands and reap the benefits of the all of the things that come with these territories. And so the Truth and Reconciliation Commission has asked us to acknowledge these truths. And in so doing, we have to teach ourselves the original relationships we had with the nations when our ancestors first arrived. We have to accept that the health inequities that exist today are the direct result of cultural genocide. And we cannot say that that's over and that's in the past, but we must acknowledge that racism is currently a root cause for chronic diseases. And we have a long way to go. So this was a publication that came out in JAMA 2022. If we think that this is solely the responsibility of Indigenous scholarship, we're skirting our own responsibilities. So currently in the US, for around 11,000 students that are accepted into med school, or for the 11,000 that were accepted into med school in the 2018-2019 academic year, only 44 were Indigenous. And of the 113,000 academic full-time faculty members who are teaching at schools across the US, there are only 274. So it is impossible for us to ask Indigenous scholars to take on this responsibility. And as settlers, we have to carry this load as well, create that space and move things forward. So I'll just give you one example of how badly things can be done. So the story of the Ongomiizwin, or the Pima community, they have been studied since the 60s for high rates of type 2 diabetes. This community lies just outside Phoenix, Arizona. And these Indigenous people have Indigenous cousins in Mexico, and they've been on these territories for years. Having seen the high rates of diabetes, the NIH moved a research center down to Phoenix and actually into the community of the Ongomiizwin. And if you just do a quick search on Pubmed Diabetes that I did as of last year, there were 831 publications. And based on what Linda just taught us, a number of them should have actually been done in partnership with Indigenous people from that community. So going back to the very first publications describing diabetes among the Ongomiizwin, no local representation as of '83, as of the early '90s, regardless of what was being studied. So in this case, we have nephropathy. We have the early discoveries in the late '90s about leptin and obesity-related adipokines. Looking at genetic predisposition for diabetes. Into the 2000s, no representation from community, racial differences in insulin resistance and blood pressure, no representation from community. And in 1998, Malcolm Gladwell, Canadian, wrote this article in the New Yorker stating that the Pima or the Ongomiizwin are now famous for having the highest rates of obesity and type 2 diabetes across the planet. However, all the investment by the NIH has not led to a single change in diabetes or obesity in that community. And as of the early 2000s, the NIH was kicked out of the community for not including community members in their scientific endeavors, but also for just using this to advance the careers of settler scientists, and not really thinking about what could best be done to help the Pima people or the Ongomiizwin in terms of reducing obesity and diabetes. And so if we turn the clock back to the 60s and the TRC had come out, and governments in the US or in Canada had really recognized the structural factors and adopted TRC called Action 18 that states that the current state of Indigenous health is the direct result of previous Canadian government policies, they would have completely changed the questions that they would have asked. So what are some of those factors that have contributed to this loss? So residential schools, as we saw in the video before us, in attempts to destroy language, culture, and land, were all things that the government knew were essential sources of health and well-being for Indigenous people in Canada. And therefore, it was a systematic approach to remove them from them and destroy those things, hence the term cultural genocide. And in this context, these things must all be included in future prevention, research, clinical endeavors that aim at improving the health of Indigenous people. We're in just past the 100th year the 100th anniversary of the discovery of insulin. This is a beautiful timeline that Taylor created. So for people in my world, we can go through this history and all of these wonderful things that have happened in the area of scientific discoveries as it relates to diabetes. However, we rarely put that in the context of the true history of Canada. And so dating back, if we want to say that rates of diabetes started to increase among children in the 90s, we have to go back to the 1800s to see where traditional food systems were eroded, where residential schools started, the Indian Act, which still is in action today, dating back to the 1870s, and the calls to action in 2015. And so when designing your research projects, you can't just focus on either this epidemiology or these discoveries. We really must put it in a context, as Taylor's done here, of the long and troubled history of Canada and Indigenous people. When it comes to research, the Ongomiizwin did have ethical approval for the work that they did, and they did have approval from the community to do this work, even though they did not engage communities. However, more atrocious things have happened. The Havasupai, the guardians of the Grand Canyon, were invited to participate in research around diabetes and obesity, and their biological samples were used to study addictions. They were used to study a number of other things that, similar to what Linda's mother had experienced, they only learned about when their young people were sitting in university listening to talks by white people about what they'd done with the biological data that they had been provided by researchers who sold themselves as doing research in the best interest of Indigenous people in that community. It's not restricted to the US, it's also been done here in Canada. And so we have a history of destroying our trust with Indigenous communities. And so we have a legal obligation to not perpetuate these atrocities and to do things in the right way. And as Linda stated, part of that is addressing the ownership, control, and access and possession of data and employing these OCAP principles to our research. But it goes back way further to this two-row wampum belt that us as maybe the epidemiological dominant group that we have the largest numbers in Canada. The original treaty, though, that we signed between the Dutch and the Haudenosaunee in and around Montreal was that this relationship would be of brotherhood. So the two-row wampum belt represents two canoes floating down the river together, side by side, two different worldviews, two different trajectories working together as brothers. And the Indian Act that we currently work with has usurped this original treaty. And so we do have a legal obligation to go back to those treaties and respectfully engage with Indigenous communities across Canada in a way that's nation to nation and not as father and son. And the best example in terms of collaborators within the CCHCSP was the development of the Anishinaabe, the Aboriginal Child Health and Wellbeing Measure by Nancy Young and her team and Mary Jo Wabino at Laurentian University. And you'll probably hear a little bit more about what Nancy's doing there. And lastly, for the scientific reason, again, I'm going to show this probably for the third time, if we fully embrace this notion, as the TRC has asked us to do, that differences in diabetes or chronic disease rates between Indigenous and non-Indigenous children are the direct result of colonization, then it has to totally reshape the way that we design our studies. So in the world of clinical epidemiology, the introduction or the adoption of directed acyclical graphs is becoming more common. These DAGs, as they're known, provide sort of a worldview of how you see an exposure and an outcome. So in this case, if we're studying indigeneity and type 2 diabetes, as you're drawing your DAG in the past, we may have said, well, it's got to be genetics, right? Indigenous people are different from non-Indigenous people because of their genes. That's not true. It also may be behavior. People are culturally different, and so may adapt and may adopt different behaviors. And these two factors come together to lead to type 2 diabetes. If you add in potential social determinants, social moderators, that Indigenous people tend to have less access to healthy foods because of the way that we have organized the reserve system, or we've reduced access to healthcare, that also may contribute to that. But in the larger scale, if we neglect to acknowledge that the true causal factor, one of the largest causal factors in all of this worldview is the actions of Canada and what I'll call white supremacy and policies and laws that are governed to propagate white development and economic and health outcomes, we're missing the bigger scientific picture. So from a scientific standpoint, not including this leaves you with a very empty and inaccurate DAG. So I'll go back to this. Do we have any brave souls who want to tell us what they wrote down? You can put it in the chat. And I'll just ask how many proximal things you focused on versus how many larger structural things that we've talked about today. And then I'll ask you to grab that pen again and write down some of the things for these racial differences here. So published in JAMA Network Open just before Christmas, we're looking at suicide rates between Black Americans and white Americans, or Black women and white women. It's the same for men and women. White people in America are maybe 4 times more likely to complete suicide than people of color. And why would you say that is? So yeah, it's great answers in the chat pouring in. If we compare these two differences, I think if we looked at the news and media, when I've been asked to talk about this, everyone wants me to talk about nutrition, chips, access to foods. When we talk about the diseases of despair in the US, we talk about structural factors that have changed the lives for this generation of white people. We immediately focus on the structures. And on this side, when it's the other, when it's people of color, white people, white media, white scientists automatically focus on the individual factors, not the structural factors. And so just looking at these two graphs, thinking about where our biases may lie, I think it helps us understand why we should take this view that we're prone to do if we think about our own tribe and apply it to other disparities between other groups of color. Again, this is from Taylor. So our responsibility to try to change the way we see these things in research is to unpack the oppressions and remove indigeneity or remove color or race as a risk factor. When we're designing our studies, we need to incorporate the structural variables that we talked about before, even though it's time consuming and even though it adds complexity. So that could either be culture, that could be nationhood. And then we also need to invest time, which we talked about earlier is challenging, and resources to understand these factors and to do the research in the right way. The best example of doing this, I think, came from Chandler and Lalonde when they're studying suicide rates in, I believe it was children in BC. And the typical graphs were always the ones that I showed earlier, comparing First Nations youth to non-First Nations youth, showing very high rates compared to the non-First Nation communities or the non-First Nation people. But Culture and Alone talked to communities and said, well, how would you like us to examine this research question? They said, well, we think culture is critical and connecting to culture is critical. So they ranked communities based on a number of cultural factors: connection to original lands, connection to original language, the amount of people speaking the language, resources for youth to connect with elders, the number of women in power, the sovereignty over education, the sovereignty over their politics. And the communities that had the highest connection to their original cultures had the lowest rates of suicide in all of BC, including non-First Nations groups. And I think if we were to draw the line for what suicide rates were in BC, it was communities that had 5 or 6 of these cultural factors present had very low rates. So just shaping it away from this Western deficit-based view and moving it into a strengths-based view and applying Indigenous teachings, we get a much more rich, a much more diverse answer to, 1, what are the determinants of suicide among First Nations people? And 2, what are some potential levers so that we can, from a public health standpoint, change it? In our own world, working with one of Susan's colleagues, Alison Dart, our original research, scientifically driven in a Western model, looked at diabetic nephropathy in youth living with diabetes in Manitoba. We adopted sort of the current biomedical Western approach to the mechanisms that would cause end-stage renal disease in kids. And then we engaged patients, community members, and elders, and they said, well, you can't study any of this until you look at the larger social structural factors and focus on the continuum. So what are some of the familial strengths? What are some of the familial challenges? What are the community factors that would prevent or modify some of the factors in there? So your DAG, your dialectical, your worldview of what kidney disease looks like becomes much broader, although much more complex, but a more rich description of what could happen. Since that time, Alison and Brandy, who are the PIs for this CIHR-funded eye care cohort, worked with patient partners and family members, engaged patient partners in not only developing the research design and research themes, but also engaged them in drawing these infographics for the manuscripts that they're publishing. They also invited patient partners to be part of the design, the writing up, and the publication. So Jackie McKee's a parent patient partner. Shayna Wokwad is a patient partner. Both of them are involved in this qualitative paper that was published in CMAJ back in 2021. Completely reshaping the way that we've done our own research and asked our own questions and changed our worldview. Going back to the Ongomiizwin, one of the community members came in and said, why don't you compare our colleagues, our cousins in Mexico to those in the US? They're living a more traditional cultural lifestyle, similar to the one we lived before assimilation or before colonization. And sure enough, when they looked at type 2 diabetes rates in the Pima or the Ongomiizwin who lived in Mexico, they were similar to the non-Indigenous people in those areas, whereas the disparities were enormous in the US. Again, suggesting that having that connection to cultural factors was a protective against diabetes in these communities. We can also look at CAMH and how they've reframed their view of determinants of mental health among Indigenous people, and they've reframed guidelines specific to Indigenous people following a team grant awarded by CHR, where they look at mental health through this medicine wheel concept of physical behaviors that'll improve mental health. spiritual connection to create hope, emotional factors that can improve mental health, such as a sense of belonging to your community, a sense of belonging to your culture, and then psychological health and ways to create meaning by improving mental health. And lastly, back to the Ongomiizwin. I wish I had this narrative, but I don't know why it was started, but I love it. Someone in the community asked if they could compare, using a randomized controlled trial, the Western approach to the Indigenous cultural approach of the Ongomiizwin. So they developed a cultural continuity intervention called Pima Pride, and they compared it to the Western NIH-derived Pima Action, which was focused on simple diet and exercise. The Pima Pride was focused on understanding their history, their cultural practices, language, and they looked at predictors of type 2 diabetes at 6 and 12 months. The action group here saw no change in waist circumference and about a 2 kg increase in weight over 12 months. The Pima Pride group, on the other hand, saw a reduction in waist circumference and an attenuation of weight gain over 12 months. And they had a 3-fold increased likelihood of remaining normal glycemic at 12 months and at 6 months, demonstrating that in a randomized controlled trial that cultural continuity outperformed Western-based education. We've done the same thing here within our group called the Indigenous Youth Mentorship Program, where we engage youth and elders and community members, the majority of whom don't have PhDs or medical degrees, in co-designing research questions and projects and things that we'll measure. And each of these communities from across 5 provinces in Canada and about 20 different nations co-develops many aspects of this work together through different gatherings. Within our dream theme, we do this from an organizational standpoint by engaging Indigenous healthcare providers, Indigenous scholars, physicians, Dr. Barry LaValle, and elders to help guide our research team to tell us where we need to go and to shape the overall themes and priorities for our research group. Where can you start as an Indigenous person working in this space? Indigenous colleagues of ours, Helen Robinson-Satie and Kathy Woods, created a learning pathway for Western-based scientists to try to learn more. It's called Wabishke Bishko Skanj. It was developed by patient partners who are Indigenous, who have been affected by kidney disease in some aspect of their life. Craig Satie's in BC right now and runs this patient partner group. And they've asked us to follow this pathway so that our journey becomes more of an accomplice, more of an ally, and less of a Western-based researcher approaching Indigenous health questions in the wrong way. Our own group has tried to adopt that pathway. Helen's here, and we've tried to incorporate 2 or 3 day trainings every year pre-COVID so that our settler scientists and trainees get trained and get introduced to these topics throughout their medical training. I just want to thank Taylor for some of those inputs, and I think this is really the future of where we're going to go, is to incorporate some of these wonderful young Indigenous scholars like Taylor and Linda, who are really paving the way for us, and we need to create space for them to succeed and do the things that they do. So in conclusion, we have moral, legal, and scientific obligations to this, and I think CCHCSP is moving in the right direction for doing this, and I look forward to answering any questions that you have on this topic.